Welcome back to my channel. In this video, I will talk about the treatment of Morton's neuroma, and more specifically, about surgical treatment using the classic technique as opposed to the minimally invasive technique, for which I refer you to the dedicated video. Morton's neuroma, which mainly affects women, is a fairly common condition in the population, although in the vast majority of cases, it does not cause any symptoms. Morton's neuroma is actually a thickening of the nerve, similar to a scar caused by excessive pressure or continuous irritation, which then causes secondary thickening of the nerve. It is interesting to note that reduced elasticity of the calf muscles may play a role in the development of this chronic irritation, causing the foot to be overloaded during the push phase of the step. For more information on this aspect, I invite you to watch another video at the end of this presentation in which I discuss reduced elasticity of the calf muscles and the most effective type of stretching you can do at home, without even needing to go to a physical therapist. The irritation and thickening of the nerve are progressive over time, leading to swelling that can vary from a few millimeters to almost 2 centimeters in maximum size. Personally, I have never seen any larger than 18 millimeters. In the vast majority of cases, the neuroma affects the space between the metatarsal bones of the third and fourth rays, as you can see in this figure. In this plastic model, you can see that each of us has nerves called interdigital nerves that pass between the metatarsal bones of the foot, which are shown in yellow. The nerve generally enlarges just before it divides into 2 smaller nerves that run toward the toes. The symptoms of Morton's neuroma usually affect the third intermetatarsal space of the foot, which you can see in this photograph, with pain and occasional electric shock sensations radiating to the corresponding toes, which may also feel numb. It is not uncommon to also have the sensation of a pebble in the shoe or a rolled-up sock. Many patients complain of pain so severe that they have to take off their shoes to massage their feet. As for the diagnosis of Morton's neuroma, I always recommend having an X-ray taken while standing, which means not on the X-ray bed, to assess whether there are any bone problems that may coexist with Morton's neuroma. I invite you to watch another video on this topic, which you can find at the link below. Magnetic resonance imaging, MRI, plays the main role in diagnosis and is therefore the test of choice if we suspect this problem, while ultrasound is much less accurate and therefore much less useful for diagnosis. For this reason, I believe that I should never prescribe ultrasound, and for the same reason, I do not request CT scans either. As for treatment, we have several options. In the early stages, it is reasonable to try conservative treatment, which may include physical therapy and orthotics, although I often find these to be of limited benefit. Local cortisone injections or injections with alcohol or platelet concentrate, also known as PRP or radiofrequency treatments, may also be considered. Surgery is only considered as a last resort. As I mentioned earlier, Morton's neuroma is frequently associated with short calf muscles, so it is advisable to start regular stretching immediately, as I mentioned earlier. We have mentioned that it is possible to perform injections of cortisone, which is injected in small quantities into the nerve, but it is also possible to use platelet-rich plasma, also known as PRP, which is the plasma obtained by high-speed centrifugation of a vial of your blood-containing growth factors. A sort of alcoholic mixture can also be injected under ultrasound guidance into the neuroma with the aim of burning the cells of the neuroma itself, thereby reducing its size. Then there are radio frequencies, which use a needle connected to a radio wave generator that also burns the neuroma cells. Radiofrequency treatment can be performed by an orthopedic surgeon or a radiologist. When conservative treatment does not lead to the desired improvement, surgery is considered, which essentially involves two techniques: minimally invasive surgery and traditional surgery with an incision of about 2 centimeters. In both cases, the surgery is performed under peripheral anesthesia, anesthesia administered to the calf, which has the great advantage of being less invasive than general anesthesia and which also offers better post-operative pain relief. I also find it to be better than spinal anesthesia, where an anesthetic is injected into the back. As for the minimally invasive technique, I don't want to dwell on it in this video, as that is not the topic we are discussing today. I refer you to the specific video, emphasizing that this is a surgical technique that involves only 2 small incisions of about 5 millimeters through which we do not remove the neuroma, but rather simply reduce its compression by cutting the ligament immediately above it. It is a type of surgery that is currently less common, as the classic technique is preferred with a longer incision, which I do not think is any more painful than the less invasive one. I will now show you the main stages of the classic surgical procedure, which is what I currently perform in 90% of cases. The surgery is performed on an outpatient basis, meaning that patients go home the same day, as soon as they regain sensitivity after the anesthesia, which, as I mentioned before, is generally administered to the calf, is not painful at all, and is performed by the anesthesiologist under ultrasound guidance. With this purple marker, I now draw the course of the interdigital nerves. In this specific case, the patient had not 1, but 2 neuromas, which is rare but possible. You can now see that I am drawing the point where the nerves divide into 2. Each half of the nerve goes to the corresponding part of the toe. Here I am drawing Morton's neuroma, and now I am drawing the part of the toes that is generally a little numb in cases of Morton's neuroma. Now I draw the second Morton's neuroma. Let's move on to the surgical incision. The incision is about 2 centimeters long, and in this case, since there were 2 neuromas, we obviously decided to remove them both at the same time. The patient has a pneumatic tourniquet on their ankle in order to minimize bleeding. Using scissors, we gradually go deeper, having to cut the ligament located just above the neuroma. The neuroma is now finally identified. I grasp it with surgical forceps and, little by little, still using sterile scissors, I isolate it from the surrounding tissue and then cut it from its medial and lateral branches. Finally, I will also cut it in the most proximal area, which you can see below. What you see now is Morton's neuroma, which I am placing on this blue surface so you can see it better. The neuroma will be sent immediately to the laboratory for histological examination. At this point, after removing the 2 Morton's neuromas in this specific case, we remove the pneumatic tourniquet from the ankle to allow the wound to bleed, thus allowing me to identify and coagulate the blood vessels to reduce bleeding after the operation. Once good coagulation has been achieved, we close the skin with a resorbable suture, which will then fall out on its own and will not need to be removed at the doctor's office at a later date. We will then apply a sterile dressing with a plaster and an elastic bandage, which we will change the following week. The surgical wound is generally protected by this dressing for a total of 2 weeks. After the operation, you can immediately put weight on your foot using a shoe with a flat, rigid sole, such as the one shown, which you will need to wear for the first 2 weeks to allow the small surgical wound to heal. During these first 2 weeks, it is best not to shower to prevent the wounds from getting wet with water thus risking infection. To avoid postoperative swelling, I definitely recommend not standing for too long or sitting with your foot down, but rather keeping it up on a stool. It is also a good idea to avoid driving a car or motorcycle for the same period of time. Physical therapy is not always necessary unless there is post-operative swelling and pain. Obviously, there are risks and possible complications, even if they are unlikely. These include infection, failure of the surgical wound to heal, with an increased risk in diabetics and smokers, and the need to wait several weeks for the residual swelling to improve. The only risk worth mentioning is the possibility that Morton's neuroma, after being cut, may create a so-called amputation neuroma, i.e., the growth of the nerve from the part where it was cut. This is a rare occurrence and causes real discomfort, requiring a second operation to remove it. The only frequent risk, and it is important that you are aware of this to avoid disappointment, is that the healing time may be longer than you might expect. It is important to bear in mind that after surgery, the scar area, especially deep scars, may cause discomfort that sometimes takes up to 6 months to disappear. These are the cases in which I generally recommend physiotherapy. Not infrequently, if the postoperative pain lasts more than 6 weeks, I suggest a cortisone injection, which is generally all that is needed to significantly improve the situation. To discuss the risks and complications of surgery in more detail, I recommend that you talk to your surgeon, whom you can always trust. Thank you for your attention. Please like and subscribe to the channel if you think this could be useful for you or others.